think we have Dr. Meenakshi now all set for her talk. She'll be talking on identifying high-risk children, prediction and preventing myopia. So we'll start with the talk, and maybe we'll, if we get time for discussion, we'll do that in the end. So Dr. Meenakshi, please.
Thank you, Dr. Rohit. A very good afternoon to all of you, and thank you, Scientific Committee, for asking me to speak on this. The topic is identifying high-risk children, prediction, and preventing myopia. The only great thing about this topic is at least I'm not speaking on progression, because that will not finish in 7 minutes. Probably needs a whole day. So most of us know this. When we talk of high-risk children, we know this. This is no-block syndrome, CSNB, Marfan syndrome. So a syndromic patient who is generally known to have myopia will usually have myopia, and so you have to screen for that. But aside from that, we are talking of children who may develop progressive myopia, that too, high myopia. So those of us, pretty much all of us are in practice, and in private practice you'll get cases like this. And the more senior you become, the more you get patients like this. A doctor couple has come to your clinic with 3-year-old son. Father wears a -1.5. Mother used to be a -7 myope, but had LASIK done. They want to know what are the chances that the child will develop myopia. Or neither parent has myopia. First child has been discovered to have myopia at age 7, who's also your patient. They want to know what are the chances of the second child developing the same, and at what age to test him. He is now 3. So really, why are we even bothered? Is it really that bad? Myopia is such a big problem? Of course. In East Asia, 80 to 90% of 18-year-olds are myopic. And 10 to 20% of these are highly myopic. The predicted prevalence by 2050 that there will be 4,758 million people with myopia, and a considerable number of these with high myopia globally. And let's look at North Indian myopia study. Dr. Rohit is here, who is the lead investigator on this. Large cohort, prevalence is 13%, higher in private schools, higher socioeconomic status, those with lesser time outdoors and more with increased screen time. And so, yes, it's a significant problem in India as well. So we're going to talk about myopia prediction first. And really, when you talk about prediction, you want to look at it scientifically, you have to look at data-driven myopia prediction. And then this falls into baseline refraction or biometric data, genetic data, or lifestyle data, or integrated data. I'm just going to touch upon this. So look at this. From 1999, that's how long we have known this, that the baseline spherical equivalent is a single best predictor for myopia onset. When you define it as -0.75, which was what the original definition was, and you add parental myopia to this mix, then the sensitivity and specificity becomes even higher. But preceding change is the best predictor of progression. So thoughts I'm going to leave you with. Many of these studies have been done in very specific populations. Can you extrapolate and apply these models to older and younger children? Like the 3-year-old that the parent brought. Can you apply them to other or mixed ethnic populations? Because many of these were done in East Asian populations. What about prediction based on lifestyle? Many papers talked about more near work, more myopia. Less time outdoors, more myopia. And so there was something called cram schools, kind of like our board exams, students. They all had higher myopia. But the OLSM, the Orinda longitudinal study of myopia, definitely said, adding lifestyle to this mix improves the prediction. The Generation R study, which came out of Rotterdam, other than all the other factors, also talked about less time spent outdoors, and no participation in sports were very important predictors of myopia. But look at this. For every paper that shows there is this, prediction, there'll be something that will say, equal number of studies will say, there is limited improvement in prediction. So we basically need more studies. What about genetic data? One myopic parent, 14.9%, 2.08-fold increase in risk. Two myopic parents, 43%, and the risk increases 5-fold. So we all know that there is gene, environment, interaction, and the most important thing is the patient comes to you with a higher genetic load, and then the higher education, the near work, is it just increasing the risk of developing myopia. So, okay, moving on to prevention. We all have been talking non-stop about outdoor time. Sydney myopia study looked at 2 hours. That's a really long time. And the Guangzhou study, which was an interventional study, put one group for 40 minutes of outdoor and one group just stayed indoors. And they looked at these kids for onset of myopia. There was a significant difference in those who went outdoors. Taiwan, all right. They tried everything. Improving room lighting, table height, encouraging distance gaze, ocular exercises. I don't know, what is this, 39 minutes intervals, but followed by 10 minutes break. They tried everything. Nothing happened. But after the education policy said, we are going to introduce 80 minutes per day, then they dropped from 17 to 8%. So all this is more important, more effective before the onset of myopia. So practice Pearl, increase outdoor sunlight time. We don't always have access to grounds but make sure there is something, sports, balcony, terrace, park, beach, somewhere the child gets outdoors. Talk to your child's school, ask the parents to speak in the PTA, not to cut out the PT period, which is what happens in most of the schools, and they have extra classes in those. And moving on to education and near work. Yes, higher IQ, more number of school years, after school tuition, all this definitely had higher incidence and prevalence. Less intense curriculum. If you have both parents myopic and the child has already started to become myopic at age 3, try and see if you can move the child to a less intense curriculum, less online extra classes, tuitions, competitive career exams. And then if you look at SMS and SCORM study, they talked about various types. Perform near work closer, 2 books per week, read more than 2 hours per day, every book read per week, everything increased the chances of myopia. So practice Pearl is elbow rule, make them keep the forearm distance between the eyes and book, 20-20 rule, take breaks, 2-hour rule, less than 2 hours screen time after school and don't sit for too long. Is it all accommodation? Nobody knows, but check for accommodation lag. Finally, the big monster, digital screen time. We've all been blaming it. But alas, there is really no clear evidence. I was very disappointed as well. But could it be that it's just near work and less outdoor time, and we're just blaming it all on the screens? So once again, just concluding, parental myopia, education, time outdoors, all have very, very strong relationship. Near work, moderate. Light exposure, moderate. Digital screen really is kind of weak there. So I'm going to leave you with 2 myopia risk calculators. One is called the Primo, and the second is the myopia calculator, which comes from the Brian Holden Vision Institute. And please take a picture of this, because this will take you to my folder, which has all the PDFs that I've used for the talk, which also has a Word document with more references. It will take you directly to my folder. And I learned this trick yesterday. I hope it works. All right. Thank you so much once again.
Thank you. I think it's apt that we're starting with the most important thing. I think myopia is a lifestyle disease. And just like diabetes, unless you don't reduce your sugar, no treatment can be successful. So unless you do a lifestyle modification, whether it's near work related, whether it's outdoor exposure, I don't think any of the interventions we're going to talk are really going to be effective.